shrug, so we're almost done. When you shrug the shoulders and one shoulder fails to shrug, you're testing for the trapezius, which is a corticospinal-like innervation by the corticobulbar tract. The transition from corticobulbar to corticospinal, it's contralaterally innervated, no longer bilaterally innervated, behaving like a corticospinal tract innervated muscle. Okay, this is just telling you the corticobulbar tracts to that lower part of the spinal accessory is purely contralateral, just like a spinothalamic tract, like a corticospinal tract innervation of your upper and lower extremities. Okay, so a weak shrug can be present with the upper motor neuron lesion, and it can also be present with a lower motor neuron lesion, and your distinguishing factors are your atrophy in the presence of fasciculations, and of course the history taking. Okay, so weak head turning. So it's a problem with the SEMs in this case. So this is the upper part of the spinal accessory, which is almost like a cranial nerve nucleus itself because of the bilateral innervation by the cerebral cortex. Okay, and it can be an upper motor neuron lesion. So transiently, meaning for the first few days after the stroke, there will be some deviation of the head away from the side of the lesion, meaning since it's innervated by let's say you had the stroke on the right side and your left SCM is weak, so the stronger side will push the head to face the other side. Or it can be peripheral, and thus again this keeps coming up over and over again. The presence of atrophy, the presence of fasciculations, and the presence of poor muscle tone will give you a clue that it is a lower motor neuron lesion.